Thank you, Dr. Sushila. Very good morning to all of you. So, imaging biomarkers in uveitis, what is new? I do not have any financial disclosures. Coming to the recent advances in imaging, we can image from pole to pole, that is, studying the cornea to the retina. Cornea is done with confocal microscopy or anterior segment OCT. Iris, we do iris fluorescent angiography to map out the areas of ischemia. Anterior chamber, we can quantify the amount of cells present by the use of anterior segment OCT. Vitreous can be imaged with ultrawide field imaging, and also we can quantify the vitreous haze with the OCT. Moving on to the retina, we have multicolor imaging, ultra-wide field imaging, which includes both fundus photography, fundus fluorescent angiography, indocyanine green angiography, and ACTA. So all can be done with ultra-wide field. The next is FLIO. It is upcoming one, that is fluorescence lifetime imaging ophthalmoscopy. In the OCT, we have polarization sensitive optical coherence tomography, that is called PSOCT. It measures the functional ability of the thing. Whatever the anatomical we see is the OCT. PSOCT measures the functional. It measures the bifringence also, and the collagen mapping also can be done with that. Next is the Ocument Biocon. Ocument Biocon, it measures the mitochondrial activity present in the retina. It measures the flavoprotein fluorescence. Next comes choroidal imaging, where we have ultrawide field imaging, which can be done with ICGA and ACTA. Laser Doppler holography is upcoming to study the choroidal vasculature changes in retinal and uveitic conditions. Next, we'll move on to adaptive optics, which has been used earlier in astrophysics. Now it has been used to study the optic disc retinal changes, and it can count the cone photoreceptors in the retina. So these are the things various available in an armamentarium. I will move on to with the pearls. So whatever we have seen in a clinical practice or what we have reported. Recently, following fever, patients can present with in the form of retinitis. Whenever you see, this is a young child presented with cerebriform pattern of retinitis with perivascular clearing. This particular pattern is important. It's morphological to suspect mumps associated retinitis. Serological or molecular diagnostics can help us to confirm the diagnosis. So whenever OCT shows disorganization of the outer retinal layers with strum-like material in the underneath the fovea. So whenever we see this kind of a pattern, we need to suspect mumps retinitis. It's another child who has again cerebriform pattern of retinitis. Here it's subtle, but whenever we see this morphology, we need to suspect mumps retinitis. So in addition to that, we also, when you do the systemic examination, they can have parotid gland enlargement, or if it's subtle, it can be picked up by the other radiological imaging such as MRI, which shows increased uptake in bilateral parotid gland in a case of a mumps retinitis. Following treatment with systemic steroids and hyperbaric oxygen, we could see the resolution with numerous scars in the retinal periphery. Whenever you see this kind of a scarring pattern, that again can give us a clue to suspect mumps, healed mumps retinitis. Next, we'll move on to another condition. We have dengue has various ocular manifestations. It can also present in the form of hemophagocytic lymphohistiocytosis, what is called HLH. Here is a patient following post-dengue fever presented with these presentations, that is cotton wool spots, retinal hemorrhages, and peripheral subretinal whitish deposits. So these are the characteristic feature of HLH. Here, when you do infrared autofluorescence, we could see the hyperreflectivity, this OCT corresponding to the areas of the cotton wool spot, whereas the peripheral whitish lesions are seen as focal aggregations in the RPE layers. So these again could be an imaging biomarker to suspect HLH. It can be due to any infections. We have seen it in dengue and also in post-COVID infections. Next comes post-fever retinitis. Many patients present with history of fever retinitis. We do not have morphological characterization to differentiate between either rickettsial, dengue, or chikungunya or West Nile. But there are certain clues. Whenever we see a patient with ring retinitis, which we have seen in a case of rickettsial retinitis, this again could be a imaging biomarker to suspect post-fever retinitis. Multicolor imaging uses different wavelength to differentiate different activities in PFR. In multicolor, whenever you see a whitish, mainly on blue-green reflectance images in active ones, in completely healing ones, you can see the grayish or grayish-white during the resolution stages. ACTA also can help us to study the vasculature changes in post-fever retinitis, where we have done the quantitative and qualitative. We have noticed deep capillary plexus rarefaction is more compared to the superficial capillary plexus. The FAZ is distorted and irregular foveal network. ACTA is not useful, especially if there is a gross macular edema. Pearl number 4, we will move on to unilateral acute idiopathic maculopathy, what we call it as UAIM. Most of the times it is idiopathic and spontaneous resolution is there. Here is a case of a 13-year-old female presented with picture. On blood culture, she had Staphylococcus aureus infection. We have treated her with systemic antibiotic ciprofloxacin, following which there is resolutions. What is the imaging biomarker here? Coming to the OCT, there is SRM, like increased reflectivity with irregular margin, decreased choroidal transmission with the distortion of the outer retinal layers. When we see this kind of a picture, we have to suspect UAIM. This is the serial OCT showing progressive resolution of the UAIM changes on OCT. It took almost about 12 weeks for the complete resolution. ACTA shows enlargement of the foveal avascular zone in superficial and deep capillary fluxes with phlovoid areas in the retinal, outer retinal layer and choriocapillary layers. However, these changes are all reversed at 12 weeks. This is a polarization sensitive OCT, shows a pace retardation map, shows the distortion of the thing at the ISOS junction. This is the normal eye and this is the affected eye. Ultra-high resolution PS OCT thickness profile showed significant thinning in the nerve fiber layer in the affected eye compared to the fellow eye. Next, we'll move on to Pearl 5. Here again, the patient presented with history of fever with decreased vision. Fundus examination, we could see the hyperemia of the disc with focal areas of retinitis with multiple retinal hemorrhages looking like impending vascular occlusion. OCT shows hyperreflectivity of the outer plexiform and enleast layer and the outer nuclear layer, which ultimately lead to localized disruptions. Whenever we see this kind of a morphology on OCT, it's a foveolitis. We need to suspect dengue infection, and dengue serology was positive in this patient. FFA shows early hypofluorescence with late hypofluorescence. So following treatment with systemic steroids, we could see the resolving foveolitis in this patient. Next, Pearl number 6. Whenever you see a patient with herpes zoster ophthalmicus, we know that it causes scarring and anterior segment changes. But when we look into the posterior segment, we can show hypopigmented lesions in the choroid. They don't present at the time. They evolve over a period of time. ICG shows dark dots. OCT shows intraretinal cystic spaces with hyporefractive choroidal granuloma. Following antiviral therapy with systemic steroids, we could see the resolution of the granuloma. We labeled it as choroidal vitiligo following herpes zoster ophthalmicus infection. Next is Pearl number 7. Here is a 76-year-old male presented with pain and redness. Here in the history, he had recent travel to South America. That was a major clue in this case. He has been treated with repeated lung infections, skin infections with antibiotics and viral infection. This is a skin lesion photograph, and he had a pigmented KPs with posterior synechiae with anterior segment reaction. Fundus, we could see a multifocal retinitis lesion in the right eye. There is a scars, and peripheral you notice there is an atrophic scars with few cotton wool spots. In this patient, because he gave history of South America, and when we did the confocal microscopy, we can see a cyst-like structure which is similar to histoplasma capsulatum. Based on that, we did the skin biopsy. The skin biopsy showed it is a case of histoplasma capsulatum. Following treatment with antifungal therapy, we could see the resolution of the imaging biomarker. What we saw as a histoplasma capsulatum on the corneal endothelium, this is completely resolved following treatment. The next is post-COVID retinopathy. Following COVID, they were giving steroids left and right, and we saw a lot of opportunistic infections, including this fungal infection.
Because time is up and we do have some more talks.
Sure.
So you can just wind
So
up.
I'll complete. Yeah. This is a rain cloud sign for suggestive of a candidal infections. This is resolved. Yeah. Can I complete with this? Yeah. Next is a paracentral acute middle maculopathy. Here the patients will complaining they have a blurring, they are not able to see, or they are seeing scotoma. The fundus is normal, autofluorescence is normal, FFA ICG is normal, visual field shows defects. On OCT, we could see the focal areas of hyperreflectivity in the outer plexiform and the outer nuclear layer. Whenever we see this kind of a lesion, we have to suspect PAM. This patient was put on echosprin, following which we could see the resolution of the lesion and the disappearance of the patient's symptoms. So, various imaging modalities and the imaging biomarkers can help us to suspect what could be the probable cause. Based on that, we can make the tailor-made investigations. They help not only in making the diagnosis, but titrating the treatment in various uveitic entities. Thank you for your attention.
Thank you very much, Dr. Padmamalini, for an amazing talk. Even I forgot the time is over because of such interesting cases that you shared with us. Thank you.
May I ask one question?
Yes, sir.
In case of dengue maculopathy, after the treatment, does it give a little residual scar or anything, or is completely resolved?
It depends upon the severity of the disease, but what we have seen is the dengue foveolitis, when they resolve, they do cause outer retinal changes.
Okay.